Hello everyone, good evening. Welcome to First Aid AMC Clinical again. And tonight we are going to do one of our free 2-week session class, right? So we have done cardiology class 1 just a few days ago, and we did syncope cluster. I hope that you understood the most of the things that we have discussed and also got an idea that how our cluster-wise approach usually works. So tonight we're going to finish cardiology, and we have 2 more clusters to finish. One is palpitation cluster and the other one is chest pain cluster. So let's start our class tonight. We will start with the palpitation or nervousness cluster first. Is there any question that you have from our last session? No? Okay, great. So palpitation or nervousness cluster, first of all, just like always, when we do a cluster, we first go through the differential diagnosis. So what are the differential diagnoses of a patient who presents with palpitation or nervousness? Especially, we are going to start with the CVS. So what are the CVS differential diagnoses of palpitation? So anything like ischemic heart disease, myocardial infarction, hypertension, arrhythmia, or valvular heart disease can cause palpitation. But the most important one is arrhythmia, and then some others like ischemic heart disease, myocardial infarction can be ruled out. Then we come to the CNS. CNS causes are not very important to rule out, but still we want to rule that out because sometimes patients who are having some CNS issues like stroke, TIA, epilepsy, infection, trauma, they can have some kind of nervousness which can cause palpitation in one way or other. So we would like to rule out the CNS causes in this case as well. So you will rule out the possibility of a stroke, TIA, epilepsy, head injury, or infection. Endocrine is very important. So hyperthyroidism, hypoglycemia, pheochromocytoma, very important to rule out. Anemia can cause palpitation, so we will rule that out. Anxiety disorder, panic disorder, or any kind of stress can be a very important differential diagnosis to rule out. If it is a patient who is in the menopausal group, especially above 40, menopause itself can present with nervousness or palpitation, so we will rule that out. Sometimes even if someone takes excess tea, coffee, or recreational drug, it can present with palpitation. And some other medication like patient who has asthma, COPD, if they take a lot of salbutamol, that can also cause palpitation. So we will always try to rule out those medication-induced side effects in any kind of differential diagnosis. So these are the main differential diagnoses for palpitation or nervousness: CVS, CNS, endocrine, anemia, anxiety, menopause, excess tea, coffee, recreational drugs, and medication-induced. Starting with the history, so palpitation comes acutely. So they will come to you that, doctor, I have been feeling racing of my heart for the last 2 hours. So something very acute. So in any acute cases, we will make sure patient is vitally stable. I hope you remember how we usually approach these kind of cases in face-to-face and online based on our class 1 on cardiology. It's the same thing. You will introduce yourself and make sure that you reassure the patient, and then you go to the examiner and ask for vitals from examiner. If it is an online exam, then you will not ask it. You will just say that you would like to check that. That's it. Once you have done it, then you move on to the palpitation question. So if you have missed our first class on cardiology, for you, how we usually start a case is just like this. So let's say patient name is Sam. I would say that, hi Sam, this is Dr. Arshan. I'm one of the doctor in this emergency department. I understand from the note that you are having racing of your heart for the last 2 hours. How are you feeling now? Patient says, doctor, I'm still feeling palpitation and I don't feel well. Say that, I'm very sorry to hear that, but now that you are here, we are going to take care of you. Before I ask you any question, I just need to make sure that you are vitally stable. So I will talk to my examiner and come back to you. Is that okay with you? Yes, doctor. That's for face-to-face, and then you ask the vitals from examiner. And what we ask in vital, we ask blood pressure, pulse rate, and rhythm, then saturation, like the oxygen saturation, temperature, and respiratory rate. In online exam, you would say that, well, before I start taking history, I will make sure you are vitally stable. So would you please tell me a little bit more about your symptom? So you will not go to the examiner, you will just say that you would like to do it and assume patient is vitally stable, and then you start asking question. We always start with an open-ended question like, can you tell me a little bit more about your racing of heart? So patient will give you some idea and you need to know answer of these questions. So we need to know when this started. Did it start suddenly or gradually? What exactly were you doing at that time? Like, were you jogging or were you at rest? So we need to know what kind of activity patient was doing when this started. Like if someone was running itself can increase the heart rate. So that's fine, right? Sometimes it can be like a sinus tachycardia. But if someone was just lying at bed and suddenly can feel palpitation, that's not normal. We should also find out that is it for the first time? Many will say that it's not the first time, it happened before. You also need to find out those previous episodes. So ask the patient, so how many episodes so far? Can you describe those events with me as well? Like what were you doing at that time? How long those episodes last? Okay. And what did you do to stop it, or did it stop spontaneously? So just get some idea about the previous episodes as well. And then ask, anything makes it better? Anything makes it worse? Is it continuous or on and off? How long each of these episodes last usually? So if patients say multiple episodes, we need to know that how long each episode lasts and how each episodes usually stop. Is it like a spontaneously or something you do to make it stop? So get some idea about the history of palpitation, and after that you move on to the associated symptom. In associated symptom, most of the patient who has got some kind of arrhythmia, they will also have feeling of dizziness or lightheadedness. So during these episodes, do you feel dizzy or lightheadedness? Most of the time it will be present. And then quickly ask the serious differential diagnosis. So serious differential diagnosis includes myocardial infarction. So ask those questions. Any chest pain, shortness of breath, nausea, vomiting, excessive sweating. And then quickly ask the CNS differential, any headache, any problem with your vision or speech, any weakness anywhere in the body, or any loss of consciousness. So basically, associated symptom is feeling dizzy or lightheadedness. Then you are going to the differential diagnosis. Initially, you asked about serious questions. So chest pain, shortness of breath, nausea, vomiting, sweating, all are MI questions. And then for CNS, headache, important. Weakness anywhere in the body is important. And vision or speech problem can be a presentation for stroke or TIA as well. After severe CNS, then endocrine. For hyperthyroidism, you can ask any change in your weather preference, any change in your bowel habit, any change in your body weight. So many patients who has got hyperthyroidism, they feel very hot all the time. So they will say that even it's very cold weather, I feel extremely hot and sweaty. So they can say that I have a weather preference, that I always like the cold environment, not the hot. So change in the weather preference, any change in the bowel habit, So what happens with bowel habit in hyperthyroidism? They can get diarrhea. What happens with weight? So patient with hyperthyroidism, they say that I feel that I have good appetite or sometimes even increased appetite, but still I lose body weight. So that's a classic picture for hyperthyroidism. For pheochromocytoma, ask any episodic headache, sweating, or any flushing of the face. So pheochromocytoma never comes in exam, but still we should rule that out. It's a classic triad of episodic headache, pallor, sweating, and flushing of the face. With that, patient also gets episodic hypertension. For hypoglycemia, just ask one question. By any chance that you skipped your meal today or any history of diabetes? If history of diabetes positive, then you go detailed questions about the diabetes, its medication, control, everything. For anemia, ask about that, do you feel very tired and fatigued these days? If they say yes, then ask more questions to find out the cause of anemia, like diet, any bleeding from anywhere, ask the malabsorption questions, okay? For infection, any infection, especially fever, sepsis, can cause tachycardia. So ask about any fever, any flu-like illness like runny nose, cough, sneezing, watery eyes. Just ask some of the upper respiratory tract questions. After that, electrolyte abnormality also can cause it. So any recent vomiting or diarrhea, especially someone who has got vomiting diarrhea, they lose body fluid, and that can also result in palpitation or tachycardia. Then that's all your differential diagnosis. So CNS, CVS, endocrine, including hyperthyroidism, pheochromocytoma, hypoglycemia. Then quickly ask about anemia, infection, and electrolyte imbalance. After that, we move on to SADMA, past medical history and family history. So for SADMA, ask about, do you smoke or drink alcohol, any medication, any known allergies, so do you drink tea, coffee, or any other recreational drugs? If patients say, yes, I drink tea or coffee, you need to find out how many cups of coffee in a day or how many cups of tea in a day. There is a lot of cases in which you get that patient drinks 8 cups of coffee in a day. What's the ideal or standard coffee or tea you can drink in a day? Usually 2, maximum maybe 2 to 3, that's highest. If someone drinking 8 cups of coffee in a day, that can itself cause tachycardia and palpitation. All right, so don't forget about tea, coffee, or recreational drugs. Ask any other past medical condition, especially diabetes, high blood pressure, or any heart condition. Any family history of sudden death due to any heart-related causes. Why we are asking it? Because many times sudden cardiac death in the family suggests there might be something going on, like it could be HOCM, could be prolonged QT syndrome, or some other arrhythmia. We also need to rule out possibility of anxiety or a stress disorder. When we ask about stress, it's not a bad idea to give confidentiality statement. Remember our psychiatry first class where we talked about confidentiality? Just say that, Jenny, I'm going to ask you some personal questions about your family. I want you to know that these are confidential between you and me. So who do you live with at home? Is there any stress at your home? Any financial issues? Do you study or work? Any stress at your work? Okay, so find out if there is any stress going on. Rule out possibility of generalized anxiety disorder. So do you worry a lot about most of the trivial things that goes on in your life? So someone who has got generalized anxiety disorder, they worry about everything. All right, so just ask about that. If it is a female patient, don't forget to ask their period history. So again, before asking the period history, say that I'm going to ask you some sensitive questions regarding your period. So is that okay with you? So when was your last menstrual period? If this is a 40, let's say 55-year-old patient, then patient can say, I had my last menstruation 5 years ago. So then you know that patient is menopausal. Ask some of the menopausal questions like, are you getting any hot flushes these days? Any night sweat? Any frequent mood swing or mood changes? Any dryness in your down below? So these are the very basic questions of menopause, like hot flush, mood swings, palpitations, night sweat, difficulty sleeping, feeling very anxious and irritable all the time. So you should rule out the possibility of menopause in this patient. Okay, so that's pretty much everything that you need to ask in a palpitation cluster. Any question with the history, guys? Once you finish the history, you just say that thank you so much, Sam, for all the history that you have given. Now I'm going to do physical examination from my examiner, and then I will come back to you. Please wait for a little bit. Is that okay with you? Okay, so just make sure you always say that I'm going to talk to my examiner now and then come back to you. So the format is always same. So your format of history is initially you introduce yourself and you greet with the patient, reassure the patient. If it's acute case, make sure patient is vitally stable. If the vital is already given on the stem, no need to make sure that patient is stable or not, because you should already know. And then start with the history of presenting complaint. In this case, it's palpitation, then associated symptom, then all the differential diagnosis, and finish with past medical history, family history, and sad note. Okay, so let's see what was your questions. Dr. Chahra, I don't understand how to take history from witness. So that's the syncope cluster you were talking about, I guess. You don't need to take history from the witness. You just say that I would like to take it. So there is no need to take it in the exam, but you just need to say that. So a lot of thing in the exam is just acting, which you are not going to do, but you just need to say. In recurrent fall case, the system that we should prioritize is based on the finding that we get. If you find something related to CNS, then CNS will be your priority in physical exam. In our case, it was the diabetes complication. So we mainly focused on diabetic complications like eye, then the nervous system, right? So it depends on your history finding. But yes, CNS plays a major role in here. Dr. Hassan, in case of online exam, how will we understand that the patient is not stable? You can't, because there is no one who can give it to you. You just assume that patient is stable because patient is talking to you, but we can't be totally sure on that part. When we know the physical examination finding, then only we can be sure. Good question. If patient complains of chest pain as well, do we need to ask detailed question related to that? Yes, you need to. Anything that you find positive in the history, a little bit of detailed question should be asked. Doesn't matter, Dr. Atia, you can ask in the past medical history, you can ask in hypoglycemia, it's okay. For medication, do we need to ask all the name of the medication? No, you just say that, are you on any medication? If patient can say, then patient will give it to you, otherwise no need. No, never ask the comorbidity after presenting complaint. That's a very poor way of asking history. The past medical history should come at the end, not along with your history. So the format is always like this. First, HOPC, then associated symptom, then differential diagnosis, then past medical history. Do we need to ask the patient about the pattern of palpitation by tapping over the table? No. It's written in many notes, but normally it's just a waste of time because patient needs to show it to you. It will not give much of an idea, all right? So we normally don't need to ask it from the patient. And many times we have heard that the role player gets irritable when you ask them to do that. If don't need to ask social history or female for LMP, do we need to do confidentiality for everything? No. Confidentiality is only for psychiatric cases and some of the sensitive questions like family history, social history, and also sometimes for the period related questions from female. You can always drop questions, Dr. Ajra. It depends on how many cases, how many tasks you have got in your history. All right. It's not like always everything you need to ask. It's totally fine based on your finding. You will already know what case it is based on your task, based on the findings patient is given to you. So time to time you can totally forget like electrolyte imbalance, infection. If you don't ask those questions, they are not going to fail you. If it is unstable patient in face-to-face, we need to go for emergency management before taking history. That's right. We will discuss that in a bit. One of the cases coming. Okay, so that's all your questions. Let's move on to physical exam. We discussed how physical exam happens in both face-to-face and online. So let's not do that same thing again and again. It's just a waste of time. So physical examination from examiner, this one is a face-to-face. In online exam, as we told, that either you get it on a card that will be given on your screen and you just need to read it, but you don't need to ask findings from examiner like face-to-face. In face-to-face, you have to ask each and everything and find out the finding from examiner, which you don't need to do from online examination. In online, either it's a card that's given with all the information, or sometimes you need to just say to the examiner that what are the physical exam you are going to do, and after that, the card will be given on the screen. So physical examination start with a general appearance. If the patient looks comfortable or in distress, ask about pickle, pallor, lymphadenopathy, dehydration, or edema. Ask about the vitals and BMI. In cardiac cases, when you ask the blood pressure, always ask about BP with standing and sitting position, pulse with rate and rhythm. Okay, but in other cases, you can just ask pulse, blood pressure, pulse, respiratory rate in that way. But in cardiac cases, we will add blood pressure in sitting and standing position, pulse with rate and rhythm. Then go to the neck. So we have already done this physical examination in our last cardiac cluster. It's totally the same one. Nothing is different. Okay. So neck, JVP, carotid bruit. CVS, you do the full CVS as we have done in our last session. And then the CNS, just then other system, you can just say you would like to do it. And finish with office test, which is urine dipstick, blood sugar, and ECG. For palpitation, ECG is must. Moving on to the cases. Supraventricular tachycardia. Very important case for your exam. Can you ask postural drop in exam? Yes, you can ask it. It's totally fine. It's not like whatever I am saying, it's not just a fixed thing. As long as you are asking it anyway, it's fine. No problem with that. So you are a junior HMO in emergency department. A man came in with thumping or racing heart with giddiness started today. Take history from patient, physical examination, ask investigation from examiner, explain diagnosis to the patient. The positive points in this case is palpitation and lightheadedness for the last 2 hours. With that patient also having some difficulty breathing. Previously, he had 3 episodes, which started suddenly, lasted 2 hours, and then stopped all on a sudden. Also, you have found patient takes 6 to 8 cups of coffee in a day. No other issue, but patient is also anxious personality and some stress is going on in their life. So sometimes in a single case, you can get multiple findings. And all those findings are important for you to mention in your explanation. So just because you have got ECG showing supraventricular tachycardia doesn't mean that you will not tell about excess coffee and you are having some anxiety issues at the moment, or you are having stress. This can also increase the possibility of this tachycardia or palpitation. So any information that you get in the history, everything should be mentioned in your explanation, not just the one. Coming to the ECG. So history and physical examination, you will follow exactly the same format that we have done. And when you do it, you will get these findings. This is the way of doing the cases as a cluster-wise approach, because we don't need to do history and physical exam with every case. We already have done it. We just know about how to diagnose it and how to manage it. Okay? Now, your third task in here is discuss the ECG or ask investigation from examiner and then explain that to the examiner. So how to read ECG in that very short time, that's what is very important to know. Okay. Now, if you have got a patient who has palpitation, which lead you will look into for the first time? Lead 2. Good. So lead 2 is the first thing that we look, because lead 2 is your long lead. Long lead means you can actually read the whole length of the ECG for this lead. So in a ECG, all of you should have a basic idea on ECG, but to give you that, so you know that there are limb leads and chest lead. So lead 1, lead 2, 3, AVR, AVL, AVF, these are the limb leads, and the chest leads are V1 to V6. Among them, the long lead is usually the lead 2, which normally we look into for the first time when a patient comes to us with palpitation or arrhythmia. If a patient comes to us with chest pain, we would look into V1 to V6 first. So as I said in the last class, that being smart is important in the class, right? Like in the exam. If you are not smart, then you will just lose time and you will not be able to finish the case in time. So that's actually the important part, that where I should look first, so that I'm not looking to the whole ECG, and then at the end I look into lead 2, and then I have found all the findings. It should not be like that, because I already know this patient has got palpitation. So in the ECG, when you get a palpitation patient, first of all, you look into their heart rate. How to measure heart rate? The best idea is that if you already know that this is the large square, right? In one large square, there are 5 small squares. So what we normally do in this case, that we divide 300 divided by number of large square in between 2 RR interval. So this is 1 R, this is 1 R. And how many large square you have got there in here. So if you look over here, the largest square is 1, a little bit more than 1. If we put 1, it becomes 300 heart rate. If there were 2 large square in between the RR interval, then divide it by 2 and it would become 150. If it was 3, then 100. If it was 4, then 75. Now, do we need to do this math in the exam? No, because we know that if there is one large square, then heart rate is 300. If there is two large square, heart rate is 150. If there is three large square, then 100. So you can just memorize this number. Then it's not very hard to say that what is the heart rate. Heart rate measuring is very easy if the rhythm is regular. So what is regular rhythm? Regular rhythm means that all the RR interval having the same space between each other, which means if you look over here, every RR interval is equally spaced. So when it is like that, that means the rhythm is regular. Regular rhythm having tachycardia and there is loss of P wave. So you remember what I said, that this is your P wave followed by QRS and T. Then again there will be a P wave, QRS and T. So this is P, Q, R, S and T. In case of SVT, this P wave will be lost. If you look on this ECG, what you see is that there is no P wave. So let's say we start from here. This is what you can see is called T wave. So all of these are T wave. There is no P wave. Okay. If you see over here, it's the same. So you have got QRS followed by T, QRS followed by T. So there is no P wave in here. If there was a P wave and patient having this tachycardia, it would become sinus tachycardia. But when there is tachycardia, the rhythm is regular and patient having loss of P wave and the QRS complex. So this is the QRS. Normally we say that QRS complex should have small square between 1 to 3. Okay. If it is very narrow QRS, then you would not even be able to find out like one small square in the QRS complex. So if you see that QRS is very narrow, that even one small square is not there, that's likely that it's a narrow QRS. So these are all the finding of SVT, which means that you will get tachycardia. So heart rate will be elevated. That means more than 100. Regular rhythm, loss of P wave, and a narrow QRS complex. Is this understandable for everyone? Do you want me to repeat it? Look on this ECG. So this is like a good ECG that can give you an idea that how the SVT ECG looks like. So supraventricular tachycardia, obviously patient will have tachycardia. So first of all, you look at that if the rhythm is regular. Rhythm regular means the RR interval is equal. If you measure here, you will find out that RR interval is all of the RR interval is equally spaced. So that's the first thing. The second thing is loss of P wave. So you can see there is QRS followed by T wave, but no P wave. QRS followed by P wave, but no, followed by T wave, but there is no P wave. So when there is no P wave, rhythm regular, patient having tachycardia, and the QRS complex is narrow. Normally QRS complex is like this, but if the QRS complex becomes like this, that's a narrow QRS. Okay, so these are the findings that we will be looking for. So when you get that finding, you will explain the ECG to the examiner, saying that, dear examiner, I would like to describe the 12-lead ECG of my patient John, who is a 25-year-old gentleman, came with sudden onset palpitation and giddiness. You can also ask the examiner, I would like to make sure that this is the ECG of my patient. We can do that. In case of online exam, you can't do that, you just explain it. The ECG shows, it depends what's your heart rate. In this ECG, it is almost 300. So you can say maybe 280, you can say. So heart rate is almost 280 beat per minute, regular in rhythm, absence of P wave, narrow QRS complex, no ST wave changes. T wave is normal in size and shape, and QT interval is normal. There has to be a format that you follow when you explain ECG to the examiner. What is that? So first P wave, followed by QRS and then T wave. Then there is P wave, followed by QRS and there is T wave, right? So the first thing that you talk about is the rate. And then you talk about the rhythm. So what's the heart rate? Is it a regular or irregular rhythm? Then first is P wave. Is there is P wave or there is lack or absence of P wave? So absence of P wave. Then QRS. Is the QRS normal or narrow or wide? So narrow QRS complex. Then you have got ST wave. Is there any ST changes like ST elevation or ST depression? But in here, no ST wave changes. Then talk about the T wave. T wave is normal in size and shape. What could be abnormal T wave? T wave inversion. T wave inversion means it becomes like this. So that's the inverted T wave. And then lastly, you talk about the QT interval. And QT interval you must have remembered from our first class. So that's your Q and that's the T wave. So that's the QT interval. How many small square is normal in the QT interval, guys? 8 to 11, right? Very good, Dr. Karishma. So 8 to 11 small square is the normal QT interval. So this is the exact way I would always advise all of you to follow when you are explaining ECG to examiner. In that way, there is a format and examiner knows that you know how to read it properly because you are following a pattern, okay? You don't need to give the diagnosis to the examiner. Once you have explained the ECG, then you explain the diagnosis to the patient. Explanation of tachycardia like this should be very simple. You don't need to explain what is supraventricular tachycardia, what is re-entry, like pathophysiology of arrhythmia, you never even will talk about in exam. Okay, just very, very simple. This is how I would say. So thank you so much, John, for waiting. As you have noticed that we have done a electrocardiogram of your heart that was taken when the nurse put those leads on your chest. Now, I would like you to show the ECG. The ECG has some lines that you can see. Those are the result of electrical impulse conduct in our heart. Now, think that this is our heart, and the heart has 4 chambers like this. The electrical impulse originates from the upper chamber of the heart, and then it goes all over the heart to pump the blood to your body. This electrical impulse is very important for pumping action of the heart. And without pumping action, the blood cannot reach to your heart as it should be. In your case, there is some abnormality in this impulse, causing your heart to beat faster than usual. That's why you're feeling this thumping or racing of your heart. Now, your heart is not getting enough time to fill in because it's pumping a lot of blood right now. Because it's not getting enough time to fill in, your brain is also not getting enough blood. And that's causing the giddiness that you are having. This is what we call as supraventricular tachycardia. Please excuse me for using the medical jargon. Now, there could be many reasons behind it, especially sometimes it can be just totally normal in young age patient. It could be due to a structural heart disease, sometimes could be related to any valve issues in your heart, could be medication-induced recreational drug intake, sometimes hormone-related imbalance like thyroid dysfunction, diabetes, could be related to infection, salt and mineral imbalance, or even sometimes excess tea, coffee intake. In your case, I have found that you are drinking more than usual amount of coffee. Normally, we say that You should not drink more than 2 cups in a day, but you are drinking 6 to 8. That can cause like this kind of palpitation that you are having. Also, you are under a lot of stress at the moment. And on the top of that, you feel anxious most of the time. That can also trigger this kind of palpitations more frequently. But it could be due to other causes. So you can give some differential diagnosis as well. And most of the time, that's all that you need. They don't ask management for SVT in the exam. Okay, so explain what is SVT and explain why the patient getting these symptoms, and then some differential diagnosis. Now, let's say if management is a task, you just need to remember what's the management, just that if it comes in exam, you know what to say. So in terms of management, it depends on if the patient vitally stable or not. If the patient is vitally stable, that means blood pressure is not less than 90/60, patient is not confused, patient is not severely dyspneic or having shortness of breath, in that case, we say patient is vitally stable. In a vitally stable patient, our initial management should be vagal nerve stimulation. How you can do vagal stimulation? You can either do carotid massage. So it's just a massage on the carotid area, which can cause vagal stimulation and can lower down your heart rate. You can also do some Valsalva maneuver. The best Valsalva maneuver can be you ask the patient to take a breath in through their nose, close the mouth and close the nose, and breathe out through the ear. So take a deep breath in through your mouth or nose, and then close both of your mouth and nose, and then breathe out through your ear, and you will be able to feel a popping sound in your ear. That's Valsalva maneuver. You can also do the same by immersion of the face in a cold water. Okay, so any of these will lower down your heart rate. If this doesn't work, the next step is medication, which you can try with IV adenosine. That means all of this should be done in a hospital. Okay, either you try IV adenosine or some calcium channel blocker or beta blocker like metoprolol you can use. But basically, IV adenosine is the best choice as a medical treatment. Even medical treatment is not helping, then the last option would be DC cardioversion, in which you give shock to the patient to change the rhythm and the rate. If patient is vitally unstable, then in that situation, you have to send the patient immediately to the hospital, and they will need to give the patient DC cardioversion at the first time. So medication is not your choice. DC cardioversion has to be done at that time. So that's basically the management of SVT. Any questions so far, guys? So management, we don't bother too much because already the task is history, physical examination, explain ECG to the examiner. So they usually don't give management in the exam. But still just know about it so that you don't feel confused if it is asked in the exam. How to ask investigation from examiner? Just say that, dear examiner, I would like to do some investigations on this patient, especially a 12-lead electrocardiogram. So what's the full form of UDT? That's urine dipstick. And then another one is BSL, which is blood sugar level. For the neck exam, do we need to check mass like enlargement of thyroid gland? No need. But if you want to, it's fine. You can always say that I would like to check the thyroid gland for any enlargement, because hyperthyroidism is one of your DD. While we are taking history during the exam, can we quickly jot down some positive point on the paper? You can. I would always say that not to do that, because it just kills your time when you're writing it, and it doesn't look that good as well. So idea is not to write it. try to remember the positive findings and then explain properly. But if you think that it will help you to write some of the specific points, you can always do that. What are the causes of set apart from tea, coffee medications? Did not get the questions, Dr. Fatima. Can you ask me again? Like, what do you mean? Like, what are the causes apart from tea, coffee medication? We already discussed that. What are the differential diagnoses? Going back to the ECG, so the QRS, we normally say that, see this QRS, basically we say that QRS should be between 1 to 3 small square. For your better understanding, if you keep it like 2 to 3, then it becomes much easier. You can keep 2 to 3 small square, that's also under normal. So if you see a QRS where the QRS only has 1 small square or even less than 1 small square, that's what we call as narrow QRS. Okay, if you look into some of the normal ECG, you can easily know what's a narrow QRS and what's a broad QRS. Is there any T wave changes here? The T waves looks fine in here. For task 3, ask investigation from examiner. Now, most of the time, if it is ask investigation from examiner, that's it. You don't need to explain it to the examiner. Everything that you need to do in the exam, it will be written on the task. If it is not written, then you don't need to do it. But we just did it because in some cases, they ask you to explain it to the examiner. How to explain ECG without drawing for online exam? We did not need to draw in this case, right? Because you can always say that, well, think that your heart has 4 chambers and the electrical impulse starts from the upper chamber and it goes all over the heart to pump the blood to your body. The thing is that you have to use your own imagination how to make it simple for the patient or for the role player. Okay, you can always change it based on what you have got. In online exam, if you can't draw, then you don't bother about drawing. You think that how I don't need to draw the heart, but still I can explain it clearly to my patient. Okay. If only asked for diagnosis, should we talk about differential? Yes, I always say if you have some time, give some differential diagnosis in the exam, but you will not fail if you don't do it because it's not a part of your task. Do we need to know the doses of the drugs? No need. Do we need to ask all the investigations for all the DD from examiner? No need. Make it simple. In SVT patient, when we will ask the vitals to the examiner, and if examiner answer the rate is more than 150, should we do any sort of management before taking further history? In SVT patient, their heart rate will be high always, but we don't need to do anything as long as their other vitals are normal. As long as their blood pressure is good, they are not confused, we don't need to start treating them immediately. In management, yes, we will be doing echocardiogram in this patient, but after managing this patient. SVT causes, basically SVT can be without any cause. Sometimes structural heart disease, valvular heart disease, those are the main causes of SVT. So we will be trying to rule that out. After we have managed this patient, we will obviously send the patient for an echocardiogram to see if there is any structural heart disease or valvular heart disease. Sometimes SVT can be related to dehydration, electrolyte imbalance, even sometimes excess tea coffee can bring the SVT. Moving on to atrial fibrillation. I know you have a lot of questions, but let's move on a little bit so that we can finish cardiology today, and then we can again come back to your questions. Okay. Middle-aged lady comes to the emergency department with sudden onset palpitation. The task is history, physical examination from examiner, investigation from examiner, explain causes and complication of the condition. So remember, the task can be anything, but when we discuss a case, we try to discuss everything, because doesn't mean task will always be like this. They can give any kind of task. But this is a tricky task that explain the cause and complication of the condition. They haven't asked you to do any diagnosis. Will you not say diagnosis in here? You will, because if you don't say the diagnosis, how you can explain its causes? So sometimes the task can be like this, that they haven't asked you to explain the diagnosis, but the task actually needs you to explain it. So in that case, yes, we are going to explain the diagnosis properly, and then we will explain the causes. Now, the history, physical examination, everything is same, just like before. The positive finding could be nothing. In atrial fibrillation, it can just happen without any particular reason. But there are some underlying cause as well that we would like to rule out. What are the cause? Hypertension can be a cause. Patient who has got ischemic heart disease, structural heart disease, valvular heart disease, even sometimes patient who has got, let's say that if a patient having like congenital heart disease, hyperthyroidism, all of this can cause atrial fibrillation as well. So we will try to rule those out anyway in our history, but most of the time you can just get patient has hypertension, nothing else. So we will come to the causes of AF in a bit, but before that, let's explain the ECG. Now you are going to tell me what you can see in this ECG. So we know that this patient having palpitation. So first of all, we will look onto lead 2. In lead 2, what I'm looking at, first thing I always look at what's the rhythm of the lead 2. Is it regular or irregular? Because I know that if it is irregular, it's likely to be atrial fibrillation. So I don't need to think a lot on that time. So if you look over here, you can see that obviously the rhythm is irregular, right? Because the RR interval is not equally spaced. Even by that, you can think that this is AF, because without AF, usually you don't get irregular rhythm in any other ECG. Still after that, we will look into the whole ECG. In irregular heart rate, or in case of irregular rhythm, measuring the heart rate is not mandatory, because it takes a long time to measure it. An examiner knows about it, and then they also don't expect that you will measure the heart rate in an irregular rhythm, because it's a little bit complex than just regular rhythm. So don't bother about measuring the heart rate in case of an irregular rhythm or AF patient. So the rate, we will say that rate is increased, rhythm is irregular, and then we look into the P wave. So in case of atrial fibrillation, the P wave will be replaced by some fibrillatory F waves. So you will not be able to find out any P wave in this patient. So if you look over here, it looks like something like this, kind of a wavy pattern. Okay, so this is called fibrillatory waves. You will not be able to appreciate any specific P wave in this case. So P wave replaced by some fibrillatory wave. QRS complex. In this case, QRS complex usually can be totally normal. You don't get narrow QRS. Narrow QRS is a finding for SVT. usually. So QRS normal, T wave normal, everything else will be normal. And if you quickly check the other leads, you can see that V1 normal, there is no ST elevation in V1, V2, V3, V4. Nowhere there is any ST elevation. Lead 1. Now the thing is that in exam, they would never give you a patient who has ST elevated AMI and also atrial fibrillation. Very unlikely. I always say that don't make the exam complicated by yourself. It is already complicated. From some of your questions, I can see that you are trying to make it complicated already. The idea is how to make it simple and pass the exam. It's not about getting 7 in the history and getting 0 in your management. It's all about making sure that you get 4 in each task and pass the exam. If you think that much complicated way, likely chance that you will miss something more important. So I always say that don't make it complicated, make it like a simple. This is a palpitation case. Patient doesn't have chest pain. Unlikely it will be a case of MI. So don't get into that in your head that I need to find that out. I will look into everything. You can't do everything in that 8-minute time. Okay, that part you will need to need that patience in your head that, well, I'm going to just look on a specific focused area and I'm going to pass this case. That should be your focus. Okay, don't make it complex. So rate is increased, rhythm irregular. Then we talk about P wave. Okay, absence of P wave, which is replaced by fibrillatory F wave. Now it depends. You can, if you find narrow QRS, you say narrow. If you find normal QRS, you say normal. So narrow or normal QRS complex, no ST wave changes, T wave normal in size and shape, QT interval normal. So as long as you look into those things that you are talking about, you're fine. Okay. So in the ECG explanation, if you look over here from V1 to V6, so someone of you asked me that why it's not MI. We're coming into the MI ECG just in 10 to 15 minutes. So hang on that thought, because let's make it when the cages come, then discuss it rather than discussing right now. So in V1, we are looking into the isoelectric line, especially for ST wave. So this is your ST wave, right? And ST wave, we can see that these are all in the isoelectric line. Isoelectric line we discussed in our last session that, so that's your isoelectric line. That means everything on the same line. If ST wave comes over here, that's the time we call it ST elevation. If ST wave goes below the isoelectric line, that becomes ST depression. But in this case, it's not like that. So you'll just say that there is no ST wave changes. I'm coming back to your questions just in a bit. Let's finish the explanation. So explain to the patient that what's the diagnosis. Now the good way is that the explanation is totally same. The SVT and atrial fibrillation, the diagnosis is different, but basically the pathophysiology is almost same. That means there is a abnormal impulse which is originating from the upper chamber of the heart, and it's causing your heart to beat irregularly. So if we come back to SVT explanation, then just explain same like that. So you will say this is the electrical record of your heart. Then the nurses put those leads. As you can see some of these lines here, these are electrical impulse conduct in your heart. And then you can explain that thing that your heart has 4 chambers. And electrical impulse usually starts from the upper chamber and then goes all over the heart to pump the blood to your body. In your case, there is some abnormality in this electrical impulse. Especially, there are some abnormal impulse originating from the upper chamber of your heart, causing your heart to beat faster than normal and also not in a regular rhythm. It's kind of a chaotic rhythm going on in your heart. That's the only difference between SVT and AF explanation. Now, because of your racing of the heart and your heart is pumping a lot, your heart is not getting enough time to fill in. That's why your brain not getting enough blood supply, causing the lightheadedness that you are having. This is what we call as atrial fibrillation. Okay. After you have explained atrial fibrillation, say that there might be some causes behind having this. Like in your case, I think that you have high blood pressure, which can cause it. Apart from that, sometimes it can be related to heart attack, coronary artery disease, which is basically the blood pipe that supplies your heart can get blocked and causing like a heart attack symptom, abnormal heart valves, heart defects that you are born with, any overactive thyroid gland, exposure to some stimulant such as medication, coffee, tobacco, alcohol, sometimes even lung conditions, previous heart surgery, viral infection or stress can even cause atrial fibrillation. Now, I also would like you to understand that once you have got atrial fibrillation, the chaotic rhythm may cause blood to pool in your heart upper chamber and it can form clots there. If a blood clot forms, it can easily dislodge from your heart and then it can travel to your brain and it can block the blood supply to your brain, causing a stroke. Because of atrial fibrillation, if it is not well controlled, it can also weaken your heart and lead to heart failure, which is a condition in which your heart cannot circulate enough blood to meet your body's needs. So these are the most two common important complications of this condition. But please don't get stressed because now that you are here, we are going to manage you accordingly and we'll try our best to make sure that you don't develop these complications. Okay, management usually not needed for the exam, but just for your idea, I would like to go through that a little bit. So we would say, again, if the patient is stable or unstable. If the patient vitally is stable, then you don't need to go for direct DC cardioversion here. The first treatment is rate control. So how to do the rate control? You can either use any of the beta blocker like metoprolol, carvedilol, atenolol, those ones. So either you can use metoprolol or beta blocker or any of the rate limiting calcium channel blocker like verapamil or diltiazem. If rate control is not helping, then the next option is rhythm control. Rhythm control are done by some anti-arrhythmic medications, which are flecainide, sotalol, or amiodarol. So any of the anti-arrhythmic medication you can use. Okay. If still after that patient is still in AF, then you can go for DC cardioversion. So that's the step-by-step management for a stable atrial fibrillation. If it is an unstable atrial fibrillation, then directly we go for DC cardioversion. Atrial fibrillation management is not over until you make sure that you have done something to prevent the complication, which is basically by measuring their Chats-Vasc score. So the Chats-Vasc score, now we are not going to discuss that in here at the moment, but just go through the Chats-Vasc score. You must have known that from your MCQ already. Once you have done the Chats-Vasc score, if the score shows that the score is 0, in that situation, we don't need to give them any anticoagulants. If the score is 1, especially if it is women, you can still wait for a score of 2 to start the anticoagulants. But in case of men, if it is more than 1, then usually we say go for any anticoagulant. What is the choice of anticoagulant nowadays for AF patient? The newer oral anticoagulants. NOACs. So any of the NOACs like apixaban, rivaroxaban, or dabigatran can be used. Okay. Only time we will use warfarin in this patient if a patient has got mechanical prosthetic heart valve and also having atrial fibrillation. In mechanical heart valve, NOAC is not indicated. In that case, you have to start them with warfarin. That's the idea that we normally follow in such cases. So you have to explain all of this if AF management comes in the exam. All right, any questions? So I'm moving into your questions. Now, sometimes I know that you have a lot of questions, but the idea is to make sure that you are prepared for the exam. And that's what I normally focus in our class. If any of you ask questions which is not needed for the exam, I will avoid it because it just wasted time for someone who actually came just to prepare for the exam, not to be a specialist. I can explain everything that you ask, but it will just waste the time. And we normally don't do it in the class as well. The important questions, that's always important. And I always like to answer it in detail. Like if someone of you asked me how to calculate heart rate in an irregular rhythm, I will not answer that because it's not needed for your exam. Okay, but if you really need to know that, then just send me a message in my messenger. I will show you and I will send the answer there. Okay, but not in the class because it just wastes the time for people who are really preparing for this exam and who actually wants to finish their preparation in the shortest possible time. Okay, going back to your questions, ask investigation from examiner means we explain the ECG to the examiner. I think I have explained that. Do we need to ask for physical examination finding one by one from the examiner to get the PFE card like face-to-face? No. In online exam, you just explain how you're going to do the physical exam. If you have done our first class on cardiology, we have discussed how to explain physical examination in online class, in online exam. Please go through that. You will get a good idea that how to explain physical examination in online cases. In online, you just say that, dear examiner, I would like to do physical examination on my patient. First, I will start with general appearance, looking for if the patient is comfortable or in distress. Then I will check his vitals, especially his blood pressure, pulse, respiratory rate, saturation. Also, I would look for pulse rate and rhythm, blood pressure in sitting and standing. Then I will check his neck for any carotid bruit or raised JPP. So one by one, you will be explaining what you are doing, but examiner will not give you any finding in online. After you have done it, then they can give you a card. It depends on the task. Sometimes you don't need to do that in online unless they ask it in the task. That's right, Dr. Pabuda. So when we ask PEFE in face-to-face, we ask two at a time. Like if we ask the examiner, I would like to know the vitals, like blood pressure with standing and sitting position, pulse with rate and rhythm. Just two at a time, sometimes maximum three, but not more than that. Now the question is that something you can't ask in a non-jargon way, right? Like especially the medical condition, you can't ask or you can't make it non-medical. Like how to make non-medical of a rheumatic heart disease. We can't do that. There is no way. So a patient who has got rheumatic heart disease, they already know about it. And they can easily say, yes, doctor, I have got this condition. Okay. So in that situation, we just ask the patient that, do you have any history of heart disease? If patient knows that they have got rheumatic heart disease, they will tell you that, yes, doctor, I have got rheumatic heart disease and my doctor explained that before. So some of these things you don't need to ask in a non-medical jargon. You just ask as a general, and if it is positive, patient will say to you. The thing is, Dr. Lily or anyone who is actually worried about, like, if anything has T inversion or not, if you get something positive on the ECG, explain that. There is no problem with that. If the ECG has ST inversion, yes, we are explaining that. Okay, but the main thing that please don't miss the important thing, which means if it is a AF case, your most important thing not to miss that there is absence of P wave, and the P wave is replaced by fibrillatory wave, and the rhythm is irregular. That's the most important thing that you don't want to miss in an ECG of AF. The positive findings, Dr. Sharwat, will be given in the exam. It will not be provided in your questions. When we'll be doing this cardiology role play with you, I think like a lot of confusions will be cleared, because right now you're still thinking what's happening, because we are just discussing the theory session, and many of you also did not come to the MSc role play class. So it is a little bit confusing for you, I understand, but let's wait until the cardiology role play sessions come, and then you will know that how actually the exam will happen. Okay. Yes, so the main exam, they will not provide the positive points like we have mentioned. You will need to find it from your history. Why MI or atrial flutter unlikely? It's not unlikely, because a patient who has got atrial fibrillation, they can get MI, but in exam, they don't give it. That's the main thing, right? As I said, please don't make it complicated. Dose is not needed. Can you please explain little, if the patient is unstable and it's online exam, what should be our approach in that case? Please repeat antiarrhythmic drugs. Thanks for explaining that. How to calculate rate in irregular rhythm. Do we give aspirin as well for AF? No, no need of giving aspirin anymore. That was our previous guideline. Nowadays, the guidelines say either you give anticoagulants or nothing. Okay, move on, because I can see that there is a lot of questions which are not actually important for your exam. So let's move on to the chest pain cluster, and you will get to understand that why, like how to actually manage a patient who is unstable. It can be unstable in online exam or in face-to-face, but how to actually manage such a patient in the exam, we will discuss in here. So chest pain, what are the differential diagnoses of chest pain? It could be CVS related causes, could be respiratory causes, could be GIT causes, musculoskeletal, neurological, or psychological. So CVS causes, mainly any patient who has got chest pain, we should always rule out possibility of angina or AMI. It's important to rule out pericarditis. It's also an exam case. Aortic dissection, aortic stenosis can present with chest pain. Then we should rule out respiratory causes like pneumonia, pulmonary embolism, or pneumothorax. GIT causes like reflux or peptic ulcer disease. Then musculoskeletal could be costochondritis or rib fracture. Then we have some neurological causes like prolapsed disc, like especially if a patient has got thoracic vertebra disc prolapse, that can also present as a referred pain as chest pain. So prolapsed disc, herpes zoster can be a neurological cause. And psychological, we should rule out anxiety-related cause or panic attack. So a lot of differential diagnoses are there to rule out in case of a chest pain patient. But please don't forget about CVS and respiratory cause, because these are the two most important ones. Okay. Now, before we move on to the chest pain cluster, I would like you to just remember this differential diagnosis. Just go through that in a bit, just for 1 minute, so that it goes into your head, because we are going to explain each of these differential diagnoses one by one for that history. So history is a little bit prolonged history in this case. So I'm giving you just 1 minute so that you can just read it. And in that time, I can drink some water. Thank you. Good. Now you know about these differentials. Let's move on. So history for chest pain is a very important history. It will give you an idea about a lot of other cases as well. So in the history, first of all, a patient, let's say 45-year-old, coming to you with a sudden onset left-sided chest pain for the last 1 hour. You need to take history from the patient, then physical examination or ask investigation from examiner, explain it to the examiner, give your diagnosis and immediate management. That's usually the case. So if a patient presents to you with a chest pain, what are you going to do now? So first of all, you're going to say that, "Hi, John, this is Dr. X. I'm one of the doctor in this emergency department. I understand from the notes that you are having severe chest pain on your left side for the last 1 hour. I'm really sorry to know that, but please don't get stressed. Now that you are here, we are going to take care of you. But before I ask you any history, I would like to make sure that you are vitally stable. So I will take your blood pressure, pulse, respiratory rate, your oxygen content in your blood, and then I will ask history from you. Is that okay with you? Let's do it as online." "Yes, doctor." "Well, John, because you are having chest pain, I would like to take you to the treatment room so that I can hook you on a ECG monitor, and then I will ask my nurse to make sure that they keep an eye on you for the duration of this time. We will also insert 2 large bore IV cannula on your both arm, and we will take some blood for necessary cardiac enzymes just to make sure that you are not having any heart attack. Is that okay with you?" "Yes, doctor." "Well, now would you please tell me that how severe is the pain in a scale of 1 to 10? Patient says 8 by 10. You say, "I'm very sorry to know that, John. Do you have any allergy to any painkiller?" "No, doctor." "Well, I'm going to arrange some strong painkiller for you. Hopefully you will feel comfortable after that." So what you have done so far, so we're doing it as an online, okay? Because we don't know the vital of the patient in online, we are following this approach. That means that we are just telling everything to the patient, that this is what I'm doing. I'm taking you to the treatment room and then ask my nurse to hook you on the ECG monitor so that we can see if there is any ECG changes. And then also insert 2 large bore IV cannula, take some blood, especially for cardiac enzymes to rule out possibility of a heart attack. And then also I will make sure that you are pain-free. So will you please tell me how severe is the pain in a scale of 1 to 10? If patients say that it's on the higher side, like anyone who is having pain above 5, always ask that, "Well, do you have any allergy to the painkiller?" "No, doctor." Well, I can arrange a strong painkiller for you. Hopefully, you will feel comfortable after that. Do you need to ask anyone to give the medication to the patient? No need, because it's all about acting in the exam. As long as you can say that, that's fine. A lot of you will say, examiner, can you please give the medication to my patient? Examiner doesn't like it. Please don't do that. I have heard some says that, well, I'm going to ask the nurse to give it to you. Do we need to say any of this? No need. You just say that I'm going to arrange a strong painkiller for you. Even you don't need to say morphine, even you don't need to say the name or dose of the medication. That's simple. It's not very complicated as you think. You make it complicated, but as long as you make it very simple and you touch the point in the exam, you're good. Okay, so just say that I'm going to arrange a strong painkiller for you right now. Hopefully you will feel comfortable. The patient doesn't need to know that what's the dose of morphine you are going to give. Obviously, when you are going to administer the medication, especially the nurse, when they come, they will say that I'm going to give you the morphine and I'm going to give you this much of morphine. Do you have any allergy to morphine? So they will explain this anyway. You don't need to do that in your exam because you will just run out of time. Now, how about in face-to-face? Let's see, there is one explanation I have got here. So in case of face-to-face exam, same thing, you introduce yourself, greet with the patient, and then you say that before I ask you any history, I just need to make sure your vital is stable. So please excuse me for a minute. I will talk to my examiner and come back to you. Is it okay with you? Yes, doctor. Thank you. So dear examiner, I would like to know the vitals of my patient. First, blood pressure and pulse. Examiner will give it to you. Respiratory rate, oxygen saturation, and temperature, please. Examiner will give it to you. Most of the time, it can be stable. Like MI patient, not always they will drop their blood pressure. Okay, so it can be stable as well. Even if it is a stable patient, still, if you suspect that this is a heart attack, or especially above 40 having left-sided chest pain, this is always emergency thing. Even if it is a stable patient, you will say, examiner, because my patient is above, like because of my patient's age and the site of the pain, I would like to take my patient to the resuscitation cubicle, attach him on cardiac monitor, ask my nurse to do an ECG and secure an IV line, and then take the blood for cardiac enzyme, especially troponin. And then if I find that my patient's blood pressure is low, I will start him with fluids. If I find that his oxygen saturation is going down less than 94%, I will also start the patient with oxygen. Okay, that's the at least thing that you can say in here. There are a lot of times in your exam, in your questions, they give you the ECG of MI, like ST elevated MI. So there is a question like that, like they give you the chest pain scenario, and then they give you the ECG, and the ECG exactly shows ST elevated MI. In that case, when you have taken the patient to the resuscitation cubicle and done everything, you can also do the immediate management immediately here. So you can say that because I can see the ECG shows ST elevated MI, I would like to take my patient to the resuscitation cubicle, keep him under close observation, ask my nurse, or you can say that secure 2 large bore IV cannula, take the blood for necessary investigations, and then also I will start the patient with aspirin. So in here, if you say the dose of the medication to the examiner, they can become a little bit happy with you. It's not mandatory, but you can say it. So you can say, I will start him with 300 milligram aspirin. Oxygen by mask if the saturation is less than 94%. Nitroglycerin if the blood pressure is stable. So you will already know if the blood pressure is stable, then if blood pressure is stable, then nitroglycerin. And the morphine, you will talk it to the patient because you will first assess what's the pain score, and then you can say that we are going to start some strong painkiller for you. So initially you can say to the examiner that you are going to start the patient with 300 milligram aspirin, oxygen if the saturation is less than 94, and given the patient's blood pressure is stable, also nitroglycerin or nitrolingual spray. Okay, so that's what we normally would do in such cases. After we have done it, then we go back to the patient and start asking the history. Okay, so once you have made sure patient is pain-free or you have given the painkiller, then you say, how are you feeling now? Is this okay for you to answer some of my questions? Yes, doctor. Then you start. So will you please tell me a little bit more about the chest pain? Patient will give you a lot of ideas or a lot of information. You don't need to ask those again. Just ask what you haven't got from the patient. So you need to know from the patient that when did it start? If from the question you already know that the chest pain started 1 hour ago, will you ask it again? No, because you already know that. If patient says that, doctor, my chest pain started 1 hour ago, and the next question that you ask is that, when did your chest pain start? That means you did not even hear anything the patient said to you. Okay, that also doesn't look very good, and examiner doesn't like those kind of approach. So find out what patient has told you, what stem has given, and then just ask questions that you need to know. So we need to know, when did it start? Did it start suddenly or gradually? What exactly were you doing at that time? Is it for the first time? Is it continuous or on and off? Now we follow the Socrates pain questions. That means we follow the site, onset, characteristic, radiation, associated symptom, time or duration, exacerbating or relieving factor, and severity. We already asked severity when we asked the pain question. Associated symptom we will ask later on, but others we are going to ask now. So we'll ask that, can you exactly point out the site of the pain for me? Does the pain travel or go anywhere? We will never ask the patient, does the pain radiate anywhere? We will ask, does the pain go to anywhere or travel anywhere? Can you please describe how the pain feels like? Now, this is a very important question because that will give you the finding. If patients say that, I feel like someone is sitting on my chest, or it feels like chest tightness, squeezing, pressure feeling, that's likely to be angina or MI. If patients say it's a stabbing, sharp pain, retrosternal, and going to the back, then we think about aortic dissection. So the type of the pain is very important. So can you describe how the pain feels like? Anything makes it better, anything makes it worse, like taking a deep breath, coughing, or doing any exertion. Very important, like if chest pain gets worse after exertion, that's related to heart. If chest pain gets worse after taking a deep breath or coughing, it's likely that it could be pericarditis pain, which gets worse with breathing or coughing. After you have asked the chest pain questions, then you move on to the associated question. So along with the chest pain, any shortness of breath, racing of your heart, any nausea, vomiting, or excessive sweating. Just like same, so these are all the MI questions. After that, all the DDs. So starting with the pericarditis, does the pain get worse when you lie down? Does it get better when you lean forward? Any recent flu-like illness? Pericarditis classic. So sharp, stabbing chest pain, and pain can be retrosternal, can be left-sided. It gets worse after lying down and also taking a deep breath or coughing. Patient sometimes sits in front of you as if they are leaning forward, just to show you that this is a pericarditis case. So they say that pain gets better after leaning forward, and most of the time you will get a history of recent viral flu-like illness. For aortic stenosis, we already know that aortic stenosis is a triad of chest pain, shortness of breath, and syncope. We already asked chest pain, shortness of breath question. So only thing is syncope question. So you can ask any dizziness or sudden blackout or loss of consciousness. That covers all the CVS causes. Then move on to the lungs. For pneumonia, any fever, cough, shortness of breath. For pneumothorax, any trauma to your chest or any known history of any lung condition. For pulmonary embolism, any recent travel to anywhere. If they say yes, you need to find out detail, that how long was the travel and what did you do during your travel? Did you sleep all the way or did you move your leg? So just to find out that if DVT causing pulmonary embolism, any previous or family history of clot formation in your legs or lungs. That covers your respiratory causes. There is a lot of symptoms in all of these cases, but we don't have that much time to ask everything. Okay, we just ask 1 or 2 questions for each of the DD. Then for GIT, reflux, does the pain has any relationship with food, any heartburn, bitter taste in your mouth? That will cover peptic ulcer disease as well. Move on to musculoskeletal. You can ask that, did you do any heavy lifting recently or any trauma to your chest? Or do you think your chest is sore to touch? If chest is sore to touch, it is most of the time musculoskeletal chest pain. Neurological, you can ask about any back pain. And herpes zoster, just have you got any painful rash on your chest? Then psychogenic, anxiety or panic, just give a confidentiality statement and ask, are you generally an anxious person? Do you worry a lot about most of the trivial things? And you can also ask, are you on any kind of stress at the moment at your home or at your work? Lastly, finish with SADMA. Smoking alcohol is a very important question for CVS. Past medical history of high blood sugar, high blood pressure, high cholesterol in any heart disease. Family history of heart disease is important. And are you on any medication? Okay, so that's how we ask chest pain questions. As you can see that the history is massive in this case. But you can always play around based on the number of cases. You don't need to ask all these differential diagnoses, especially the case where you already know that this is a MI. When you can see the ECG on the question, you don't need to ask all this history with differential diagnosis because you already know the case. So in that case, don't bother with asking too many differential. But if patient only comes to you with chest pain and you don't have an ECG, and your task is ask history for 6 minutes and give you a diagnosis and DD, then all of this detailed history should be taken. That's why we kept such detailed history in here, because sometimes it comes in that way. Clear everyone, the chest pain history? Good. Dr. Atia, so you asked that with the arrhythmia and chest pain complaints, should we make sure the initial treatment has been given or not? Can we ask from no? There is no need to ensure that. As long as you say it, that's all that you need to do. Cool. Physical examination, same. Nothing is different. Just don't forget one thing, that when it is a chest pain case, we also ask that apart from S1, S2, is there any added sound like any murmur or any pericardial rub? Because in pericarditis case, you get pericardial rub positive. Now, going to the case, which is pericarditis. But before we do that, I would like to take a 5-minute break for your brain to take a little bit break so that whatever I am talking about, you know, at least you are not sleeping. Okay, so 5-minute break for everyone, and we will also just during this 5-minute break, we will just show you the course detail, so that in case some of you are new here and you don't know about the course, you have lots of questions about it, you can listen to the video which we have been showing for the duration of this 2-week session, so that you get an idea about the course. And after that video, we can again start the class. Okay, so that's the plan. If you have already enrolled, you know about the course, take this 5-minute break and then come back after 5 minutes. All right, everyone. Thanks for listening to the video. So that should be enough. I think our 5-minute break is done. We can start. How to differentiate reflux, peptic ulcer, hiatus hernia? That's the case of GIT. Dr. Pavoda, in GIT lecture, we will discuss that. Hi, Dr. Arshan. Okay, Dr. Alistair. I will remember that. Just stay after the class is finished. Okay. All right. So let's start with pericarditis. A 50-year-old tram driver presents with sudden onset chest pain for the last 2 hours. Focused history, physical exam, diagnosis, and DD. That's your task. Now, a 50-year-old having chest pain, we should always first think that it is a MI unless we can prove it otherwise. Doesn't mean that a 50-year-old cannot have pericarditis. It can, but we will think it as our second or third differential diagnosis. So in this case, they haven't given you any ECG on the stem. When you ask the history, you will find out that patient having chest pain for 2 hours. It's aggravated by lying down and deep breathing, relieved by leaning forward, and it's a stabbing type of pain. Sometimes it also can radiate to the back and had a flu-like illness a week before. Okay, so that gives you a diagnosis of pericarditis anyway. When you come to the ECG, this is a ECG of pericarditis. Even by the history, you will have an idea in your head that I am looking for a pericarditis ECG. And if you can confirm that in your ECG reading, that gives you the full confirmation of the diagnosis. So your history physical examination is same like before. In this case, in physical exam, when you do auscultation, you will not get a murmur, rather you get a pericardial rub. Sometimes examiners say that, yes, you can hear some pericardial noise. So pericardial noise is actually pericardial rub. So how to read this ECG? Now, in a chest pain case, we are starting from the chest lead. So V1 to V6 is the chest lead. We are one by one, we will have a look. What we are looking for? We are looking for a ST elevation. That's our main thing that we look for. So in V1, we can see that it's normal. There is a little bit of T inversion here, but no ST elevation because it's in isoelectric line. In lead 2, now there is a ST elevation here, we can see. In lead 3, this is more prominent, right? Can you guys appreciate the ST elevation, that what's actually ST elevation? Because if you understand it, it's not very hard. But if you don't understand it, it's really hard. Yes, good. So if you understand ST elevation, so ST elevation, basically you just find out where is the isoelectric line and then you look at the ST interval or ST segment, you can easily find out. Then you V4, you can see that there is ST elevation, V5 ST elevation, V6 a little bit of ST elevation. So you understand that from V2 to V6, all the leads having ST elevation. Then after chest lead, if you get ST elevation in the chest lead, immediately you look on the high lateral leads, which is lead 1 and lead avial. Because many times you get anterolateral MI, which means that ST elevation in the chest lead and also ST elevation in lead 1 and avial, which we call anterolateral MI. So to find that out, you look on 1 and avial. So in lead 1, there is ST elevation. And then in lead AVL, a little bit of ST elevation, not that much, but still there is a little bit. So we have got ST elevation almost in every lead so far. Now, this is the most important part, not to forget. If you have got ST elevation in the anterior leads, you should get reciprocal ST depression or even ST normal in inferior leads. So what are your inferior lead? Lead 2, 3, and AVF. So we say that if you have got ST elevation in anterior lead, there should have some reciprocal ST change. So ST elevation should not be there in the inferior lead, rather either ST depression or normal. Now that's the main finding. If you look on here, you can see there is a ST elevation in lead 2. Lead 3 basically normal, just there is T wave inversion. And lead AVF also having a little bit of ST elevation, right? So that's not a reciprocal change. This is what we call as diffuse or global ST elevation in almost every legs. When you get ST elevation in every legs, high lateral, inferior, anterior, that's the time we don't think about MI anymore. That's usually found in a pericarditis ECG. And also one of the other findings that you get, if you look on this ST elevation, it looks like someone can sit on this ECG. It's called like a concave shaped, so concavity upward, or I say chair shaped ST elevation, like you can sit here. So that's also a classic picture that we see in ST elevation for pericarditis. Is this understandable for everyone, that how to differentiate between MI and pericarditis? Great. So now that you have confirmed that it is a pericarditis case, then you say that most likely from history, physical examination, and the ECG, you are having a condition called acute pericarditis. Do you know what it is? No, doctor. Well, it's a condition where there is an inflammation of the outer layer of our heart known as pericardia. Most likely it's due to the recent viral infection that you have got. As the covering of the heart is inflamed, it's causing this stabbing type of pain that you are having, which gets worse when you lie down and get better when you lean forward. There could be other reason as well. Now, could be heart attack, but I can assure you that your ECG doesn't look like that. And also the symptoms that you have told me, it doesn't go with a heart attack. Also, it could be due to other condition like sometimes valvular heart disease, but you don't have any symptoms related to that. It could be any lung conditions, then say most of the differential diagnosis that you can talk about. But to confirm my diagnosis and to exclude heart attack, I still need to put you under observation in the emergency department for the next 3 to 4 hours. In between that, we will do some investigation, especially full blood count, inflammatory marker, which can get elevated in pericarditis. Kidney function test, because sometimes if there is any kidney issue that can also cause this pericarditis. We will also repeat the ECG to see if there is any changes later on. And we do a cardiac enzyme called troponin, and that can exclude possibility of heart attack. The specialist will also come and review you, and if he wants, he might also want to do an echocardiogram of the heart, which can also confirm the diagnosis. If it is confirmed just to be pericarditis, then there is nothing you need to worry about. You just need to take some bed rest, and I will give you some painkillers, especially some anti-inflammatories, which can reduce the inflammation and also resolve your pain. Okay, now for the moment, I would advise you just to take rest. If you want to call your partner, friends, or relatives, and that's also fine. Just tell them that we are not thinking about any heart attack. It's likely to be a pericarditis. You are in a safe hand with us, and we will take every possible care to ensure that you get the best possible management. Do you have any questions? Okay. Always finish with something nice. Like I always finish with something nice and easy so that patient gets some reassurance. Okay. It's very important that how you finish the case. Because the patient is in hospital, we don't do this 4-hour. I'm not discussing the 4-hour today. We will discuss in one of the other class where we are getting the pediatrics vomiting cluster. We will discuss about this 4-hour. Okay. So that's how we do this explanation of pericarditis. Any question, guys? Which one, Dr. Pramodia? The last bit, reciprocal. Okay. Reciprocal means that if you have got ST elevation in chest lead, like V1 to V6, in the inferior leads, which is lead 2, 3, and AVF, the ST should be depressed or just normal, should not be elevated. But in this ECG, you can see in inferior lead, like lead 2, 3, AVF, still there is a ST elevation, which is not usually we find in case of myocardial infarction. If it was a MI, if you get ST elevation in this chest lead, we will be looking for either it's a normal ST or depressed ST in these inferior leads. Okay, Dr. Pramodia and Dr. Purnata. Now, acute MI case. A 55-year-old man comes to your emergency department with sudden onset crushing chest pain. Your task is to take history, physical examination from examiner, ask investigation from examiner and explain the likely cause of his chest pain and immediate management. So this comes with immediate management in the exam. So, and many times investigation, which is the ECG given on your stem. In this case, you will find out patient have an acute onset of severe chest pain, which is crushing in nature, radiating to neck, jaw, and left arm. Associated nausea, vomiting, shortness of breath. So a classic picture of myocardial infarction is that patient comes to you with a sudden severe left-sided chest pain, which feels like a crushing, tightness, pressure, heaviness feeling. It can radiate to the neck, jaw, and left arm. Okay, and sometimes associated difficulty breathing, nausea, vomiting, and excessive sweating, and sometimes even a fear of death. So that's what are the positive findings you will be getting in this case. Obviously, you remember that any patient who you suspect to have a chest pain, especially middle-aged or elderly, we will always follow the same protocol. We take the patient to the resuscitation cubicle, attach to the cardiac monitor, do the ECG, take the blood, and then do the monotherapy. The monotherapy is the immediate management for a heart attack patient. So mono first is aspirin 300 milligram orally, nitroglycerin, you can give it sublingual, oxygen by mask 6 to 8 liter per minute, and morphine. That's usually the treatment at the first. Once you do the MONA, you also call the catheter lab to send the patient for emergency coronary catheterization to find out how much block it is and to put a stent inside. So we'll come to that just in a bit. Have a look to the ECG first, how the ECG actually should look like. So let's have a look to this one. Do we give colchicine in acute pericarditis? You can, but initially we will always start with NSAID, like yes, ibuprofen or indomethacin, any of the usual NSAID we will use first. Colchicine usually only if still after giving the anti-inflammatories, patient is not getting better, then you can add colchicine or even a steroid. Okay, now what are the findings in here? Guys, tell me now, this is your time to tell me, what are your findings? Just tell me if you can get any ST elevation, and if yes, where are the ST elevation? Okay, let's see that if you are right. So V1, no ST elevation, this is fine. V2, there is ST elevation because ST is here. V3 is more prominent, V4 prominent, V5 prominent, V6 prominent. So almost all the V2 to V6, ST elevation. Then we go to where? Lead 1 and AVL, right? Lead 1 has got ST elevation. Then we go to the AVL. AVL also got ST elevation. So that's what we are calling as anterolateral MI. After that, how we know that it's not pericarditis? We look onto the lead 2-3 AVF. You can see that lead 2-3 AVF having normal ST elevation, right? So like normal ST, there is no elevation in here. That means that's also okay. So this is anterolateral MI, but it's not a pericarditis. If it was a pericarditis case, you might got ST elevation in lead 2-3 AVF as well. Okay. So this is also another ECG. You can see same ST elevation. There is a little bit on V1, V2, V3, V4, V5. Not much in V5, V6. Lead 1 has ST elevation. Lead AVL has ST elevation. Lead 2, it's actually we can't see anything. Lead 3, fine. There is a little bit of T inversion. Lead AVL is fine. So that's how we find out that there is no change in the lead 2-3 AVF, but it's also anterolateral MI. Normally, I would not say the monotherapy initially if I am not totally sure that it is a MI case. If I am sure, like if the question already gives me the MI ECG at the first, then I will do the MI monotherapy initially in the immediate management, like when we are talking to the examiner. But in pericarditis case, they don't give you the ECG. In that case, you just take the patient to the resuscitation cubicle, but don't start the MONA. Just send the blood and then hook the patient with ECG. Okay. So management. So in this case, how we are going to manage a patient, that's also important. So you will say, thank you so much for waiting, John. Based on the nature of your chest pain and according to the electrocardiogram, most likely you are having a condition called acute myocardial infarction or heart attack. Give a little bit of pause for the patient to understand what's going on, because it's actually very shocking for anyone. And then say, I'm really sorry, but John, it is a very serious condition and it can be life-threatening as well. In this condition, the blood pipes that supplies your heart gets blocked by clot. And as a result of that, part of your heart muscle doesn't get any blood supply, and sometimes it can get totally non-viable if we don't manage it as early as possible. If it is a face-to-face, it's very easy to explain. You can just draw the arteries and show it. But if it is online, it's tricky, but examiner knows that. They will not be like disappointed if you just explain it. So, but explain that in this condition, the blood pipe that supplies your heart gets blocked by clot or some fatty deposition. And as a result of that, part of your heart muscle doesn't get enough blood or oxygen. And that's why that part of the heart can get non-viable and it can lead to serious complication. But please don't get stressed, because you are in safe hand, and it's very good that you have come early, and with proper intervention, it can be managed very serious complication. We always follow the sandwich approach, in which initially we say that this is life-threatening complication or this is very serious condition. But again, we always reassure at the end, because if the patient is with you, you can actually treat the patient effectively without having this complication. John, I need to admit you to the hospital immediately. I will call my senior who will come and review you, and also we will call the cardiologist who is the heart specialist for further management. In the meantime, I have already given you a tablet called aspirin, which you have Like it depends. If you have already given initially, you just say that you have already done that. If you haven't done it initially, then if you say it now, still they will pass you. It's totally fine if you forget to mention that initially, but now in your management, you are saying that because it's totally okay. So in the meantime, I'm going to give you a tablet called aspirin, which you need to chew only. I have already given you a strong painkiller and will continue until you feel comfortable. That's the morphine. If your oxygen content in the blood goes down less than 94, which normally should be near to 100, we will also start you with oxygen. If you have ongoing chest pain, we will also give you another medication called nitroglycerin, which you need to take under the tongue. Okay, so that's the monotherapy, which means morphine, oxygen, nitroglycerin, and aspirin. The specialist will come and see you and might want to do further investigation, starting with some basic bloods like full blood inflammatory marker, liver kidney function, thyroid function, blood sugar, lipid profile, and a cardiac enzyme. The definitive treatment of this condition is to remove the clot and restore the blood flow, what we call as percutaneous coronary intervention or thrombolysis. This will be decided by the specialist based on the duration and severity of your condition. So idea is that if a patient presents to you within 12 hours of onset of the symptom, you can treat the patient with either percutaneous coronary intervention, which is basically angioplasty, and if it is not available, like you are in a rural hospital, then you can do thrombolytics, which is a streptokinase retiplase or alteplase. So your immediate management is up to this. That means if you can at least say that definitive treatment is to remove the clot and restore the blood flow by some specific measure called PCI, percutaneous coronary intervention, or thrombolytic medication, which will be decided by your specialist based on the duration of your condition. If you have some more time, you can say that, well, usually the guideline says that if you come within 12 hours of your onset of symptoms, which you actually did, and you are in the tertiary hospital, most of the time we will be able to send you to the catheter lab, where there will be a range of specialists who will try to remove this clot. So normally what we do, that we put you under sleep, and then we insert a catheter from your groin inside your heart arteries, where we look into the specific area where it is blocked and then try to remove the clot. And sometimes a specialist might also want to just to put a stent or just a balloon so that your heart artery is wide open, and that will help to restore the blood flow. If that is not available, or if it is not possible to be done, then there are other medications which can also dissolve the clot. But this is a specialist decision, and he will discuss each and everything with you, and you will be given all information, and only after taking your consent, they will proceed with that. Now, there is a lot of things written in here. I normally don't do that because this patient having an acute AMI, we are not talking about discharge straight away. We will say that, John, I know that this is a lot to take at the moment, but I also want you to know that you are in the safe hand, and we have a very good team of cardiac doctors in here who treat patients like you every day. And with appropriate measure and intervention, most of the time we are successful. But it's understandable if you are stressed. And I want you to know that if you have any questions, anything that you want to know, I will be here. Just ask me and I will answer it accordingly. If you want me to call your friends, family members, or anyone, please let me know. I will be happy to do so. If you have any questions, please let me know. Okay, so just finish in this way, and that should be enough for this case. For MI, the pain should be treated with morphine. For any other chest pain, the pain should be just start with paracetamol, like NSAID, then go up. Normally for MI case, I haven't seen they ask the physical examination that much. Okay, usually because they're giving you management, they focus on the management more than PAV. And if they ask for a task where you have to do the physical exam, it usually comes after history. And always follow the order of the task. If your order is history, physical examination, ask investigation from examiner, then explain. You first start with the history, then physical exam, then investigation, then explanation. So order of the task should be followed. Question, Dr. Hassan, that we know that troponin takes at least 4 to 6 hours to get elevated. Do we need to do it if the patient comes before that? We normally do it just as a baseline, but obviously it will not give any idea. The idea is if someone has got ST elevation, troponin doesn't matter. So if someone has got ST elevation with a chest pain, that's ST elevated MI. You will not treat the patient after getting the troponin value. You will treat the patient without that. So doing it doesn't make any difference if it is a ST elevated MI. But if you think it is a MI, but there is no ST elevation, it could be still a non-ST elevated MI. So then troponin is very important. Yes, Dr. Nijatul, within 12 hours of onset of symptom, you can do PCI or thrombolytic. Now, there are a case where patient is in the rural hospital, and then you don't have time to send the patient to the tertiary hospital. In that case, you have to go for thrombolytics. And yes, you will have to ask for any contraindication of thrombolytics in that case. Description of PCI is not needed unless if you have some time. It's always a good idea to explain it. Same, Dr. Purnata, in here is the same. Like initially, we actually did it like the online one, how we are going to do it. We will just tell the patient that because you are having the chest pain, I would like to take you to the resuscitation cubicle, ask my nurse to attach you on a cardiac monitor and do the ECG. And then we will secure some IV line, take some blood for necessary investigation, and then we will wait for the ECG to come. That's just chest pain without the ECG case. If ECG is there, in that situation, actually it's not ideal to say the monotherapy initially to the patient. The reason behind is that because you haven't explained that what is the diagnosis to the patient, and we normally would not do it. In case of online exam, we would rather just keep it until this, that take the blood, find out the ECG, and then if needed, give the oxygen. We will not explain monotherapy in online exam because we still haven't taken the history. We haven't discussed the other task yet. And at the time when we come to the diagnosis, then we just explain to the patient that this monotherapy, okay? So that will be ideal for online. But for face-to-face, because you can discuss it to the examiner, just discuss this initially. Dr. J, medication to the patient, not to the examiner. You can use the generic name, that's usually the best idea. There is a case, Dr. Huria, where they give you MI ECG first in the stem. No, Dr. Nijatul, it's not a critical error. You can't diagnose non-ST elevated MI with history. You have to get the ECG will be normal, and only way is to get the troponin. Only with the troponin you can diagnose non-ST elevated MI. The history is not enough. No need of clopidogrel or BNP in this case, because clopidogrel is an antiplatelet agent. And if you're going for PCI, you just make the patient to bleed more if you give clopidogrel at the moment. So ST elevated MI, which needs urgent operation, we will not give clopidogrel straight away. It will be given after the operation and when you are discharging the patient. And nothing to do with BNP, because that's we do for heart failure. So no need. Okay. Clear, everyone? So that's actually everything that we want to discuss tonight. There is few cases left, especially the case that we haven't done is the CVS risk factor. CVS risk factor is also important. So there is a chart that they gave, and in that chart, they ask you to assess the CVS risk factor for the patient and then explain it. So what is the plan that when we do the CVS or cardiology role play with you, in that role play class, we will do that first, and then we will do some role play. Okay. So that's the only case that is left. So in a nutshell, in this case, if it is an acute MI, let's say they have given you the ECG. And ECG, you can see that it is a MI. If it is a face-to-face case, you will take the patient to the resuscitation cubicle, and everything like cardiac monitor, IV line, bloods, and then you will also talk about the monotherapy to the examiner. Then you come back to the patient and do the history. If it is an online case, an ECG showing myocardial infarction, what will you do? You will start with the normal greeting, reassurance, and you will say that now, I'm very sorry that you are having chest pain. Please don't get stressed. Now that you are here, we are going to take care of you. Before I ask any history, I just need to make sure that you are vitally stable. So I will check your blood pressure, pulse, your oxygen saturation, and then we will make sure that you are stable enough to talk to me. Also, because you are having chest pain, and especially on the left side, I would like to take you to the treatment room. We will also ask the nurse to attach you to a ECG monitor and take the ECG first. And also we will insert 2 large bore IV line so that we can take some blood and send it for necessary investigation. Is that okay with you? Yes, doctor. And then you say that I know that the chest pain must be very severe. Will you please tell me how severe it is in a scale of 1 to 10? And then you just finish your history. And when you come to the explanation, then talk about the monotherapy as part of your immediate management. That's for online. What type of troponin will be checked? This is a question where you think more, which is not needed. Do I need to say what kind of troponin we are going to do to a patient or even to an examiner? They don't care. As long as you can say troponin, you're fine. But normally we do the troponin I. But do I need to be that much specific? No. The idea is very simple. You are going there as a junior doctor. Don't think you as a specialist. You are not going for a MRCP exam, or you are not going there as a consultant. You are a junior doctor. If you can at least say troponin, they are happy with you. So just act like that. As long as you are doing that, you will not be in trouble in the exam. It's most of the time specialists fail this exam, not the junior doctors. Yeah, so if it is a stable angina pain, it will subside after taking rest. So pain duration of angina is less than 10 minutes. That's it. Face to face, if we don't get ECG first, do initial management, then history, and after getting the ECG, only do the MONA. That's right, Dr. Pabuda. That's the idea. Because as when we only know that this is the AMI, then we do the MONA. Not everyone needs a monotherapy. All right, everyone. So that's it for tonight. Now you must know that there are few classes on random role play class. So Dr. Cynthia takes those classes for you. She is very beloved teacher among everyone. So you will also enjoy her class, I hope. So the classes will be on 11th of May and 11th of May and 14th of May. And in between that 13th of May, there will be a cardiology role play session. So back-to-back 3 role play sessions. I'm sure you will get a good idea how the exam actually happens. Right now you're thinking, am I going to get all the findings like Dr. Arshan is saying? It's actually not like that. But when we do those role play, things will become much clearer for you. That's the reason of taking the role play class. So just remember that the role play classes will not be live on Facebook. So you have to join the Zoom session, and the Zoom ID will be different for those role play class. So just keep an eye on the Facebook for the Zoom ID and just join just like you're doing right now. Okay. Thank you, everyone. We'll see you again in the next 3 or 4 classes that we are left for 2 weeks free session. If you have any questions, anything that you want to know, feel free to ask it always. We are more than happy to answer any questions, as long as it's not that what you don't need. Okay? Thank you all. Take care. Bye.